Assalamu alaikum everyone. We are going to start the series of lectures on congenital heart defects in CVS medicine, which are broadly classified into acyanotic heart diseases, cyanotic heart diseases, and obstructive heart diseases. In acyanotic heart diseases, today we are going to talk about a very important topic, that is VSD or ventricular septal defect. As the name indicates, there is a defect or hole in the interventricular septum. It is one of the most common congenital cardiac defect and constitutes about 25% of all congenital heart defects. It may be membranous, that it involves the membranous part of interventricular septum, and it may be muscular, that is it involves the muscular part of the interventricular septum. But this membranous involvement is more common as compared to the muscular involvement. VSD may be classified into small or restrictive size of the hole, that is less than 0.5 centimeter square, moderate, that is 0.5 to 1 centimeter square, and large or non-restrictive, that when the size is more than 1 centimeter square. Now look at this diagram, that in this case there is a hole in the interventricular septum and there is a shifting or shunting of blood from left side of the heart into the right side. That is, oxygenated blood is entering into the right ventricle, into the deoxygenated blood. That's why this is acyanotic, because the oxygenated blood is moving towards the deoxygenated blood. But due to the movement of blood from left side of the heart into the right side of heart, there is a volume overload on the right side of the heart, and with the same high flow volume, the pulmonary circulation, there is a high flow volume in the pulmonary circulation and returns back into the left side of the heart. So on both sides there is a high volume of blood, that is volume overload. It can lead to, due to this volume overload, that hypertrophy of both the ventricles occur, which may leads to cardiomegaly. Now look at the pathophysiology. There is a left to right shunt, and it depends on the size of defect and the ratio of systemic to pulmonary vascular resistance. And due to volume overload, the biventricular hypertrophy occur. Now look at the Eisenmenger physiology. It is basically when there is a continuous blood flow from left side of the heart back into the right side of the heart, there is a compensatory constriction of the pulmonary blood vessels. Due to compensatory constriction of the pulmonary blood vessels, there is pulmonary irreversible hypertension developed. Due to pulmonary hypertension, there is a reversing of shunt, that is from right side of the heart the blood backs into the left side of the heart after chronic process. So this is called Eisenmenger physiology. Now this is no more the acyanotic disease. This becomes the cyanotic heart diseases, because the deoxygenated blood is entering into the oxygenated blood. This is called Eisenmenger's phenomena or Eisenmenger's physiology. Now look at this slide. When the pulmonary hypertension occurs, the pulmonary vessels resistance is increased than the systemic vascular resistance. So the shunt becomes reversed and the patient becomes cyanosed. So this is Eisenmenger physiology. Now come to the clinical features. The clinical features mostly depends on the size of defect. If the defect of the size of the defect or the hole is of smaller size, then the patient is asymptomatic, but both the heart sounds are normal. That is normal S1 and normal S2. There is pan-systolic murmur at lower left sternal border. That there is a murmur can be heard by stethoscope. This is pansystolic or holosystolic. Throughout the systole there is a murmur, because there is a shifting of blood from left side into the right side of the heart, or shunting occurs mostly during the systolic phase. That's why there is a murmur, is pansystolic or holosystolic murmur. But in the moderate VSD, there is a left to right ventricular shunt. The clinical features include increased pulmonary resistance. It is a compensatory mechanism for long-term process of shunting. So during infancy, there is a tachypnea, feeding difficulties or feeding problems, recurrent respiratory tract infections due to high pulmonary blood flow, and growth retardation because of the poor feeding of the child or infant. And there is congestive cardiac failure, because of the biventricular hypertrophy can lead to this congestive cardiac failure. And the congestive cardiac failure may occur. Systolic murmur with normal first heart sound, this is the pansystolic murmur, and second heart sound is split with louder P2. This louder P2 is because of the pulmonary hypertension. So loud pain systolic murmur at left lower sternal border. That is, throughout the systole, the louder pain systolic murmur can be heard. Now, in large ventricular septal defect, as there is excessive pulmonary blood flow which results in the pulmonary hypertension. This results in dyspnea or difficulty in breathing, difficulty in feeding, and sweating with poor growth and recurrent pulmonary infections because of the pulmonary congestion and pulmonary high blood flow. The chances of the heart failure in early infancy are more as compared to the small and moderate defects, and cyanosis during the cry is the important feature. And also there is a bulging at sternal edge. Loud P2 is because of the pulmonary hypertension. Diagnosis is done by multiple methods. The first investigation is chest x-ray. If the VSD is smaller or the defect is smaller, then chest x-ray is normal. But in larger defects, as we have discussed previously, due to volume overload, in larger defects, cardiomegaly may be seen in the chest x-ray, and there is increased pulmonary vascularity, and there is enlargement of left atrium and left ventricle and pulmonary hypertension on the chest x-ray if the size of the defect is large. But the definitive test is echocardiogram. It picks up the defect size as well as it gives the size and location of the defect. So the echo is the definitive test in case of the ventricular septal defect. So the ECG shows in large defects there is biventricular hypertrophy, and P wave may be notched or peaked, which indicates the atrial hypertrophy or atrial enlargement. Now come to the last but not least, the management. If the size of the VSD is very small, then just reassure the patient. But for the large VSD, there are two main aims. One is to control the congestive heart failure, and the second is prevent the development of the pulmonary vascular disease, because to prevent the Eisenmenger phenomena. And in large VSD, growth failure, so maintenance of the growth is also important. So now come to the medical management. As we have discussed in the previous slide, these infants with the large VSD often fail to thrive, so maintenance of the growth is impaired. Congenital or the congestive heart failure is treated with digoxin, which is positive inotropic agent, and diuretics, and to reduce the afterload, medications should be given to the patient. But if the patient does not respond to the anti-congestive measures or show any signs of the pulmonary hypertension, then surgery is indicated without any delay. Now come to the surgical management. Most of the cases of irreversible pulmonary hypertension can be prevented by a surgical repair of large defect before the 2 years of the age. The indications for the surgical intervention include intractable heart failure or refractory heart failure, which is not treated by medical treatment. That is, medical treatment failure, then repair or by the surgery is important during the first year of life. So the other indications include for the surgery that pulmonary hypertension, that if pulmonary hypertension develops, the surgical repair is necessary to prevent the vascular changes before 2 years of the age. And when there is a chronic overload of the blood volume, the needs of surgical repair between the 2 to 5 years of the age. The primary closure of the defect with the prosthetic page is now used for virtually all the asymptomatic singular defects. The indications of the surgery, as we have discussed in the previous slide, that indications include failure to control the congestive cardiac failure despite of the medical management, failure to thrive if the child within 6 to 12 months of age with rising pulmonary hypertension. So the main aim is to prevent the pulmonary hypertension, to prevent the Eisenmenger phenomena. If the child is more than 2 years and the pulmonary blood flow is more than the systemic blood flow, then it is also indication for surgery. Suprasystal VSD, associated pulmonary stenosis, if the development of aortic regurgitation is associated with the ventricular septal defect. So these are the indications for the repair by the surgery. The prognosis is usually that 35 to 50% of the defects will close spontaneously during the first year of life, and vast majority of the defects that close will do so before the 4 years of age group. The complications include, as we have discussed previously, the patient may develop the congestive cardiac failure, repeated episodes of the respiratory tract infections, and growth failure or failure to thrive, infective endocarditis. Because when the high flow blood from the left side of the heart enters into the right side of the heart, there is a damage to the endothelium of the right side of the ventricle. So there are more chances to develop the infective endocarditis because the endocardium becomes more vulnerable to attachment of the bacteria. Other complications include the hypertension, that is pulmonary hypertension, Eisenmenger phenomena or Eisenmenger syndrome, that is reversal of the shunt with the cyanosis. So let's end this lecture with this scenario. A 2 months old baby girl was doing well, but now she presents with the poor feeding, sweating, and respiratory distress. On examination, she has tachypnea, normal pulse with marked heave, and soft holocystic or pancystic murmur at the left lower sternal border. Liver is palpable, that is hepatomegaly, and the chest X-ray shows cardiomegaly. So this patient has developed the heart failure as well. So what is the diagnosis in this case? This patient has ventricular septal defect because these all are the features of the VSD. This is advanced VSD. The patient has developed the features of cardiac failure as well in this case, that is liver palpable and cardiomegaly as well. So the diagnosis is ventricular septal defect. The investigation includes the chest X-ray initial investigation, ECG, and the echo. The most important one is echo because it will detect the size of the VSD as well. The management is the medical as well as surgical repair we have discussed previously. So this was whole about the ventricular septal defect. Thank you so much for watching this video.